I guess we'll get started with our next session. We're going to speak a little more in depth about topography and using it in your ortho-k practice. So we'll go over some of the concepts that we started with in the morning and maybe enhance them a little bit. My disclosures haven't changed since this morning, so they're still the same. And let's begin with the case. What do you think about this eye? Is this a good candidate topography for ortho-k? What is it that you look at in this map or in the data that suggests to you that this is an easy, a moderately tough, or a very difficult case? You know, what are you looking at when you look at the topography by itself, the contours, the shape? What is it telling you? So let's break it all down. First, we could talk about the radius, and we know that orthokeratology tends to be able to create more effect on the steeper cornea. So the steeper the eye, the better the potential for ortho-k. If you're dealing with a 40 diopter flat K and a -8 patient, that might be tough to achieve target on. If you're dealing with a 44 diopter cornea and a -8, then you got a better shot at it. So the steeper the cornea, the better the potential for effect. Look at the shape of the astigmatism, clearly with the rule, but if you look at the type of astigmatism, is it apical? Is it limbus to limbus? Is it somewhere in between? When you look at that hot meridian running vertical, how far does it extend across the eye? And here you can see most of the contours are confined to the center of the cornea. There's almost green 360 degrees around, like the peripheral cornea is very spherical in shape. So this is your apical astigmatism. This is a very good candidate for ortho-k. So steep cornea and apical astigmatism tells me this is a good patient eye for ortho-k. Now, the next one is eccentricity, and we talked a little bit about this. The higher the eccentricity, the better the potential for ortho-k effect. Normal eccentricity, depending on your topographer, is about 0.55 to maybe 0.65. For this instrument, 0.65 is normal. So this would be a very normal candidate eye for ortho-k. If we had a 0.2 eccentricity, meaning the cornea is very spherical in shape from center to periphery. So we're not talking about spherical Ks. We're talking about how much does the eye change from this point to the periphery. What is the rate of corneal flattening? The higher the rate of corneal flattening, the higher the eccentricity, the better the potential for ortho-k. Now, why? Orthokeratology sphericalizes the central cornea. If the cornea is already a sphere, it's hard to move the cornea in that range toward sphericalization. It's already a sphere. So the higher the eccentricity, better potential for ortho-k. Now, visible iris diameter, not so much a candidacy metric, but it's certainly used to guide you on whether you're going big or small in diameter. You may have heard from other speakers, typical construction of lens in terms of diameter is VID less 0.8. So if you have, in this case, an 11.4 visible iris, we're probably starting with a 10.6 lens. Some designers like to go within about a 0.5 millimeter of the visible iris, so it really depends on the design. But with VID less 0.8, that's kind of a safe range, gives you a lot of room for the lens to move in the closed eye environment without impinging out there on the limbus. Pupil diameter, of course, super important to us in myopia control. If we're trying to signal the eye to slow down, we've got to push the defocus into the eye. If you've got a pinhole of a 3 millimeter pupil, we're going to have a hard time optically to send the signal to slow down. So the bigger the pupil, the better. 5.4 millimeters is considered the average pupil size in normal illumination for a child. 5.4 millimeters, normal size for a child. So anything bigger than that, then we're probably going to be able to push more defocus signal into the eye. Anything smaller than that, then you have to be conscious whether you're using soft multifocal or orthokeratology or any optic intervention. How am I going to pack the defocus into that smaller space. So pupil size matters. Sagittal differential is one that you use to determine parameters. And it's kind of like looking at K readings. What are the Ks? How high are the sill? So sag differential looks at where the lens will land out at 8 millimeters. And what we do is you measure the height of the eye across the flat axis to an 8 millimeter chord, and then the steep axis. So what we're talking about is how high is the mountain in microns across the flat, and then how high is the micron, the height of the eye across the steep axis. The difference between the two is your height differential. So think of it like your corneal astigmatism. Is it 2 diopters of corneal sill? Well, in this case, we have a difference of 36 microns difference between the flat and the steep axis. What does that mean to you? 36 microns, kind of a useless figure by itself. But if your eye has 30 microns or greater of height difference, that's where you want to think about using a toric landing. Anything under 30 microns, a symmetric landing lens is probably going to work just fine, and it's difficult for you to see the difference between a symmetric and toric when your height difference is under 30 microns. But over 30, that's when you'll probably notice a difference between fitting the patient in a symmetric landing. It's probably going to be moving excessively, maybe rocking a bit. There'll be a lot of that dumbbell kind of pattern that you were taught to look for. So 30 microns and greater, use a toric. For this patient, we need a toric landing. Whoops, sorry. 36 microns for this eye, so definitely a toric landing case. Now, you can look at the baseline corneal topography and predict where the lens is going to go. The lens has to follow the natural eye displacement. If it's decentered, temporal, or inferior, that's where the lens is going to want to go. So draw an imaginary circle around where you think you see this green-yellow border, and that's where I think it is, where I've drawn that circle. And it's telling me that it's going about 0.44 millimeters toward axis 239. In other words, my lens is going to go slightly inferior temporal once it's on eye and the patient closes their lid over top of the lens and it's got hours and hours of sleep. That's most likely where the lens is going to position. So if you're looking for perfect centration, textbook bullseye topography after ortho-k, probably not going to happen on this eye. It's going to follow the natural eye displacement, and that's temporal inferior on this eye. Now, the topographical astigmatism is one that you absolutely can't control for, and it's one that gives you probably the biggest headache in ortho-k. How can you push away the corneal astigmatism and therefore the refractive astigmatism? So pick one of those eyes that you think is the easiest of the three to fit in orthokeratology lenses. Then pick the one that you think is the toughest to fit in ortho-k. And we said earlier that apical astigmatism is easy to work with. You can generally push the astigmatism out of the way. This patient with limbus to limbus sill, it's very difficult for us to move that steep meridian out. Partly because if you look at the red, it runs almost from one side of the eye to the other. It's a spherical vertical meridian. And remember we said low eccentricity, it's harder to push it out of the way in ortho-k. So if you needed a -4, -2 sill, you need 6 diopters of flattening on, let's say, this axis right here. If that patient has 0 eccentricity along the steep meridian, how are you going to get 6 diopters total of flattening? So astigmatism is tough in ortho-k. It's the area I think we're the least predictive in. We're very predictive in adjusting the myopia, flattening the central cornea. But moving out astigmatism, it's hit and miss. Sometimes you can just squeeze it all out of the way, sometimes very little. Here's a good example where we started with an apical, mostly apical astigmatism, 1.67 diopters of corneal sill. After ortho-k, we basically cut it in half. And studies tell us in orthokeratology, it's typical that you take your baseline corneal astigmatism and cut it in by 50%. So if you start with a patient that's 1.5 diopter sill and leave them plano or plus 50, minus 75, they can probably handle it. But if the sill is higher than that, then obviously it's going to be tough if we're only taking away 50%. So don't be surprised by that. Thankfully in kids, they're so insensitive to the astigmatism, what we leave for them generally. Now here on this limbus to limbus astigmatism, you see the hot contours, all of them, yellow, orange, red, all running from one side of the eye to the other. Then post-wear, notice how we've really not pushed that hot meridian out of the way. You haven't sphericalized, or I haven't sphericalized the central cornea. Pre-ortho-k sill was 0.75, post-ortho-k was 0.79. We've actually increased the sill doing ortho-k on this patient. So limbus to limbus is a very challenging eye to fit. I wouldn't say don't do it, but just be aware that it's going to be tougher. It might require more lenses to get there, and in the end, you might not push the sill out of the way. So if the patient's super sensitive to it, it's going to be a problem. So look, baseline topography. Look for whether you have apical astigmatism or limbus to limbus. That might guide your fees as well, because an apical astigmatism is very easy to manipulate. A limbus to limbus is going to be tougher. It might be more visits, it might be more lenses. So again, that might be a slightly higher fee in your schedule. Now we talked in the earlier section about what analysis to use. There's so many, and it is just overwhelming to look at all of the different analysis options. Really, you're just going to focus on a few in general practice and the same number in ortho-k. Basically, it's axial, tangential, elevation. And we said earlier today that the axial is the best way to interpret the power of the eye. So in this case, if we look at the left topography, your nice little apical with the rule astigmatism, you can easily correct that eye with glasses, with soft torics, with corneal, certainly GPs. That patient is going to achieve a very high level of visual acuity because the anterior surface shape of the eye is ideal to bend light, or at least it's slightly astigmatic, so as long as we correct for the astigmatism, we'll achieve a high level of acuity. But here, you notice there isn't really a flat and steep meridian. We have a very asymmetric eye. How do you correct that with spherocylinder refraction? So your axial map tells you what kind of visual potential does this patient have. Now clearly we're not fitting the keratoconic on the right side there. We're not fitting that patient with ortho-k lenses. But you get the idea. Axial is to understand vision. Tangential is to understand shape. So the same two eyes, now interpreting them as a tangential map. And this is the best way to understand where the eye radically changes in curvature. In the case of our keratoconic on the right side, what is the size of the cone? What is the position of the cone? These are the things that we learn from a tangential map. In the more normal eye on the left side, what you might learn from the tangential map in this case is where is the periphery that your lens will land and find its equilibrium. So really in your baseline analysis, I don't use the tangential very often, unless it's in a regular cornea, post-surgical cornea. These are the kind of cases where you might be using it. Now the third map that we use with some frequency is the elevation map. And this tells you where the lens will land and where it'll lift. So where you see red, that's where the elevation of the eye is high. That's where a contact lens is going to hit hardest and hit heaviest on this eye. So for this with the rule patient, it's going to land across here, it's going to land across here, you're going to have vaulting here and here unless you have a toric on eye. So the blue is telling you the eye is depressed. It's going in, it's going back toward the back of the eye. The red is telling you the eye is elevated, it's protruding, it's coming forward. So in our keratoconic patient, we can see that we might have landing across here, maybe arcuately all the way around, but right here is an abyss. That's the edge of the cliff. So that's your keratoconic eye curving radically and dropping in elevation. That's why you have all the pooling in those keratoconic patients, because the cornea is steep, but more importantly, the cornea is losing elevation. So red means the elevation is high. That's where you have landing. Blue is where the eye is depressed. That's where you have pooling. Now, another tool that you might use is your contact lens software in your topographer. You can build your ortho-k lenses from these analyses options. And this is a wonderful way to appreciate the tear layer profile underneath the contact lens. And you've seen a bit of that in lecture today for sure, where some of the software fitting systems explain to us how to build a lens across the flat and steep meridian and possibly 360 degrees around. So ortho-k lenses are really well designed from these contact lens softwares. I'm not suggesting you should do this right off the bat. If you're brand new to ortho-k, definitely takes time to get to a point where you can manipulate this lens to have the right apical clearance, the right tear reservoir depth, appropriate alignment, healthy edge lift, all those things. But you might move yourself in the direction of getting control over all of those zones of the lens. And once you can understand the tear layer profile, you are an expert at orthokeratology. Okay, so how do we arrive at a lens like this? How do we get a good orthokeratology lens fit? What's the key? Now, one of the easiest things you can do, especially as a neophyte, is just export the maps to your lab. They import it into their fitting software, and they build a lens for you. So super easy. Let's just call this the empirically ordered lens. If you can send not the PDF, but the full exported digital data, then they're able to manipulate the map the same way that you are. So that's one way we can order a lens. Another way is we can collect the data from the map itself. We punch it into a software or a nomogram. That's another way that we can use the topography to construct lenses. Another method is to use third-party software, export the digital data, upload it to the third-party fitting system, and there's numerous options in this regard. All of them very good, so don't let me try to suggest you any one is better than the other. And then the final one that we just talked about would be to use your topographer's fitting software to build the lens. So my point is, you've got lots of different ways that you can build a lens. You can do it empirically, sending the data to the lab. You can use fitting software, third-party fitting software. You can punch the data into calculators, and you can use the contact lens software. So lots of options, all of them good. Now, one of the things that's a very contentious topic, and my mentors made it very clear to me, no matter how good you get at ortho-k, you're never going to be able to use this as an appropriate analysis of the fit. So how do we look at the fluorescein and not get some value out of it? The problem is that these lenses do not work in this environment. So we're evaluating the fit, the centration, the edge lift, the apical clearance. We're evaluating all of these things in this open eye, but that's absolutely not how the lenses work. Of course, they work in this environment. So what is the fit going to be when the patient closes their eye over the lens? Now, I'm not suggesting that the fluorescein pattern is useless to you. It has value, but just use it with a grain of salt. That if it looks acceptable, if it looks dispensable, then let it go, because ultimately the lens is going to work with the patient sleeping, closed eye for a whole bunch of hours. A perfect ortho-k lens should have about 5 to 10 microns of apical clearance in the center. Can you tell me how much fluid is underneath that lens right there? We can see fluorescein at 20 microns thickness. That's where the fluorescein molecules are dense enough that we can pick them up behind the slit lamp. So if we can see fluorescein at 20 microns thickness, but a good ortho-k lens should be 5 to 10 here, how can you possibly say that the ortho-k lens is ideally clearing the central cornea? You just can't. If you look at the reservoir here, how deep does that need to be? Can you tell that it's 70 microns or 40 microns? Tough to tell. So you really can't use the fluorescein in a real meaningful way. What the textbooks tell us, at least John Mountford's textbook tells us that what it's useful for is telling you gross or extreme appreciation of the pattern. But anything in between, it's going to be difficult to use. So that's where we rely on topography, to look at the epithelial changes that we've made to appreciate what happened in the closed eye environment. So let's focus and rely on the topography. Fluorescein should look acceptable. The lens should center reasonably well between blinks. The lens should be adequately comfortable. It should not appear to hit the central cornea. If it hits the central cornea, usually it goes lateral. So we're looking at those things, but ultimately what we want to know is, can we dispense this lens? We look at the fluorescein. So the post-wear exam is really focused on, did the patient have a healthy physiologic response? That's obviously the most important thing. What's our vision like? But then we really just want to get to topography so we can appreciate, have we gone down the right path? Because there's no way to tell what you've done to the epithelium until you see the topography. So we use those subtractive maps that we talked about. The axial tells you the RX change, the treatment zone size, treatment zone position, the myopia controlling effect. The tangential tells you the position of the lens in the closed eye environment. So we're going to use all of that analysis to guide us. So here's an axial interpretation, and I've overlaid the fluorescein pattern so you can get a sense of what part of the lens is doing what effect on the eye. So where the lens is super close, where the fluorescein looks like there's zero, like there's touch, that's where the hydraulic force is pressure. It's pushing down on the epithelium. So you get this blue area of flattening. So the axial map describes where the lens is super close to the eye and creating those compressive push forces. Ortho-k is not done by mechanically pushing in the epithelium. It's done by hydraulically altering epithelial shape. Now, this is your axial map of this case, and one of the first things we might do is click our cursor right in the center and determine the refractive change. So you don't have to do a refraction in ortho-k because the axial map will tell you what RX change you've created. If you have, let's say, 45 diopters before ortho-k and 42 diopters after ortho-k right in the center, that's this number. That's the foveal change that you've created. So it's very convenient to use the subtractive map. Click your cursor in the center. You don't have to do a refraction for the patient. Next is treatment zone position and size. And you might follow this red ring, the green-blue border, where you have the extent of your treatment area. And that tells you both the position. It will tell you about vision. If the treatment area is decentered or too small and the patient is visually struggling, you know why. It's because our treatment zone isn't big enough or isn't centered enough for the patient. Measuring across from 0 to 0 effect, that's where you determine the treatment zone size. So look down on this graph right here. The 0 point is where I haven't altered eye shape, all the way across to this point. So across the center is your flattening. That's your hydraulic push force pushing down. And where that minus adjustment, that flattening, reaches 0, that's the end of the treatment zone. So you can take your cursor right along the flat meridian, steep meridian, any meridian, and you go to the point it reaches 0, that's where you have the end of your treatment zone. We talked a little bit about displacement. We look at the baseline eye. Right in the center is the visual axis. Now I want you to draw a circle around that green-yellow border. Would you agree with me on this left eye that the red circle is displaced up and out, or temporal superior? And when you look at your post-wear response, the cross in the center is your visual axis, your patient's fixation point. And then when we draw the the green-blue border in, you can see it too is displaced superior temporal. Lenses do not always go to the position of the displacement. Sometimes lid force has influence. Sometimes the parameters are off and the lens just wants to go where it wants to go. But about 70% of the time, the lens will go, 75% of the time, the lens will go where your baseline topography is. So this is helpful to look at before you start ortho-k, because if somebody told you you need to alter the centration of the lens, but the eye is decentered up and out, that's where the lens is probably going to want to go. You probably can't influence the centration because you're just fighting nature. So baseline eye, really important to look at. You might look at the pre and post Ks. I hate Ks as a way of building an ortho-k lens. They're not very useful when Ks are taken at 3 millimeters and we're going to fit a 11 millimeter contact lens. But they're useful for understanding the corneal astigmatism. Before ortho-k, we were 1.64. After ortho-k, about a diopter. So orthokeratology is not completely sphericalizing the central cornea. So these are helpful numbers if your patient is struggling with some kind of visual disturbance. Check out that pre and post astigmatism, see if that's a factor. Now, we talked about the tangential map also being a useful analysis, tangential for shape, right? And we use that to understand the position of the lens. So here, looking at the fluorescein pattern, where you have the reservoir being the deepest and thickest, that creates this red ring. That's where you have the suction force pulling on epithelium. So it's completely opposite to what we talked about in the center, where the central area where the lens is close to the eye is producing compressive force. Where you see the red, it's producing suction force, pull force. Now, the red ring is describing the reservoir. The next one out, the blue, is describing the alignment zone. So you can use the red and blue rings to tell you exactly where the lens was positioned when the patient was sleeping. And they become absolutely obvious. So you're going to use both the axial and the tangential in your analysis, but for different things. Axial for vision, tangential for lens position. So here, when we look at the red ring, where is it in relationship to the pupil? Would you agree with me that the lens is slightly temporal, maybe a little bit superior? Look how the red ring is inside the inferior pupil, so it's slightly high, and then the red ring is outside the pupil margin here versus on the pupil margin here. So you're just looking at those subtleties of where that red ring is in relationship to the visual axis, the center of the topography, or the black ring, the pupil. So this is like one that practitioners rely very heavily on, and you often see lecturers use only a tangential map, and they'll use a tangential map to understand power, but it's not correct. The tangential is used for one thing only, nothing related to power, purely where's the lens position. The axial is anything related to vision or power. So again, we might look at the baseline eye and look at that green-yellow ring. Where is it in relationship to the pupil? And that's often where your findings will be post-wear. So you can use that displacement of the baseline eye to understand where the lens is going to be post-wear. Okay, so this outcome is called the bullseye. This is where your blue treatment zone is very well centered to the visual axis and the pupil, and it means you've done everything right. You can have a bullseye that undercorrects or overshoots, but a bullseye tells you you've centered the effect. So whatever your alignment zone is, it's appropriate for the eye. It wants to be centered in the closed eye environment. And this is half the battle in ortho-k. When the patient comes back after one night, the only thing I care about is whether we're moving in the direction of a centered bullseye response. Of course, we care about the physiologic response, but topographically, we're looking for the bullseye as our goal of treatment. So the bullseye means you've done it right. Now, this is a good orthokeratology outcome, right? It's a bullseye, but I want to ask you if this is a good myopia controlling bullseye. You've created good orthokeratology treatment, but have you created good myopia control treatment? So what do we look at? And we call this at Pacific University the myopia defocus dosage, or what you might just call the blur, the defocus. And what we're looking at is this action within the pupil. So just focus on this graph down here. If we assume a 5 millimeter pupil, what is the power distribution within that 5 millimeter diameter? So what I might do is look at the most minus in the center. In this case, we're creating 3.12 diopters. At the border of the pupil, we're creating 0.4 diopters. The difference between them is 2.72. So most minus 3.12, least minus at the border of the pupil, minus 0.4. The difference is about 275. So think of this like the add power in soft multifocal lenses. How much add have you given the patient to slow down that eye growth? How much defocus are you presenting to the fovea? So this is an important number when you assess your post-wear outcomes. Do you create a big, huge blue LASIK optic zone or treatment zone where there's basically the same power all the way along a 5 millimeter zone? There'd be no defocus. There'd be no signal to slow down eye growth if your treatment zone is humongous. If your treatment zone is small, then it's going to create more spherical aberration. It's going to create more defocus within the pupil. It'll create better myopia control. So this is an important one. So don't just look at whether you've created a good bullseye and whether you've created good ortho-k effect. Have you created good myopia control? Now, here's a response that we see not very frequently. I would say this one is the least frequent topographical outcome. And as you can see, you've got this blue treatment zone or moat that surrounds this island right in the center. And if you look at the area of the blue-green border, typically it's decentered low. Now, what do you think would be a low position GP lens? Flat or steep? Typically steep, right? Low position RGP, normally it's a steep fitting lens. What would you presume would allow the epithelium to get sucked up in the center to create that steep island? It's got to be a lens that's a mile off the eye, right? So this is your central island response, and it's caused by a lens that's too far off the eye, a lens that essentially is too steep. If we switch over to the tangential map, what you usually see is a nice red ring, but that red ring is displaced low in relationship to the visual axis and the pupil. So central islands, like I said, are not very frequent, but they're generally caused by the apical clearance being too far off the eye. And it might be evident in your fluorescein pattern. If you've got boatloads of central fluorescein, instead of having what appears to be touch, then you know you probably want to drop the sag, especially if it's associated with central island. They're also caused by a lens too tight in the periphery that's squeezing in the periphery and not allowing the center to change. Could also be the diameter off. So look at all of those things. Check your VID, make sure your lens diameter is appropriate for the eye shape. Does the fluorescein pattern show you an edge that has no edge lift, that it's completely black all the way around? And then do we see tons of apical clearance? Easy to resolve. We just drop the apical clearance, flatten the alignment zone, and that usually does the trick. Now here you can see the blue treatment area in the center positioned high in relationship to the pupil. And that gives you an associated little smile down here. It could be humongous, it could be very acute, but ultimately you see that blue treatment zone riding very high in relationship to the pupil. This is what's called the smiley face, and this one is very, very common in orthokeratology. Often because when the patient closes their eye over the lens, you've got all these tension forces, lid tension force, pulling the lens up. So you might have the perfect fit, but you get a smiley face just because the alignment zone is not tight enough. If we go to the tangential map, again, we're ignoring the blue in the center. We're looking at the red ring, and you can see how high that red ring is in relationship to the black pupil there. So a smiley face outcome, very easily resolved. It's typically just tighten up the fit. If you have a patient that's got lots of central corneal staining, the lens is crashed into the central cornea and it's decentered high, that's a lens that needs the height increased The lens is too low, it's touching the central epithelium. Do you remember how much apical clearance we said a good orthokeratology lens should have? Like 5 to 10 microns. So if the lens is crashing into the central cornea, that would be no good. We need to raise the height of the lens. If you have smiley face topography and there's no central corneal staining, there's no central bearing, no touch, then all you need to do is tighten up the alignment zone, neutralize the lid force so the lens will come down. So just to repeat that one more time, if you've got apical bearing, you need to raise the height of the lens, you need to tighten up the alignment zone. If you have no apical bearing, no central corneal staining, and you have smiley face, then you just tighten up the alignment zone. Here's the next, also one that we see with great frequency. Notice it's the opposite of the smiley face. The blue treatment zone decentering low in relationship with the pupil, creating this frown, this upside down smile, the frown. Excuse me. So this one is completely opposite in every way. If the smiley face is loose fitting, this one is tight fitting, resulting in that low position. If we go to the tangential map, look at your red ring. Look at your blue ring. Here we can see the red is well inside the black pupil here. It's below the pupil here. The blue, what did we say the blue was? The alignment zone, right? The alignment zone is just inside the pupil margin here, and it's well below the pupil, somewhere down there. So use the red and the blue rings to understand your centration. The frowny face is generally resolved very simply by loosening up the alignment zone. The lens is tight in the periphery, it's wanting to ride low. It's just the same as normal corneal GP fitting. Loose lenses ride high typically, steep lenses ride low typically. Ortho-k is exactly the same. High riding lens is loose, low riding lens is tight. The final is your lateral displacement. And you might check your baseline topography to make sure that you have a lens that's not following natural eye displacement. In this case, I look at that green-yellow border, and it looks kind of symmetric with the center. It looks pretty equidistant here to the green as here to the green. So I don't predict that the lens should be riding significantly temporal on this left eye. So why is it? Probably the lens is way too loose. So here you can see the blue treatment zone riding very temporal of visual axis and the pupil. And when we go to the tangential map, you see the red ring well a millimeter inside the pupil here, and then at the pupil border over here. The blue ring at the pupil margin here, more than a millimeter beyond on that side. So you're looking at those red rings in relationship with the pupil margin. That's what makes it easiest for you. So lateral displacement is usually resolved by either increasing the lens diameter, you've got a lens too small and loose for the eye, go bigger, or if the lens looks like it's an appropriate diameter for the eye, then tighten up the alignment zone. It's too loose. Could happen on an against the rule eye. It could be that as an alternative. Sometimes these ortho-k lenses just decide to go where they want to go. And there was a question in the morning session, can we control how patients sleep? And I swear there's times where kids just sleep with a knuckle in their eye and it just totally decenters the lens. It's a perfectly centered, good looking fit before we dispense it, but the patient comes back with an utterly lateral topography on just one eye. So is it related to the sleep? I don't know, but there's these outcomes, especially lateral, where you just can't understand why it's doing what it's doing. So in such cases, bigger, tighter, that's what you have as options. Could be the toricity too, if you've got a lens that is symmetric in landing and it's a toric eye, that could also be a factor as well. So these outcomes, bullseye, central island, smiley face, frowny face, lateral displacement, they are going to guide all of your decisions in ortho-k. As an example, if you have central corneal staining, that means that the lens is inadequate in height. Which one of these outcomes would you be modifying that would increase the sagittal depth? That's the smiley face, right? If you've got a lens that shows no edge lift whatsoever, and you've got a patient that's uncomfortable with the fit, which one of the changes is going to loosen up the alignment zone? Which one is the steep fitting lens? That's the frowny face, right? So you can use all of these topographical responses to guide how you alter the lenses. Now here's a one-night response, and I'm going to do something you should never ever do in practice. You never look at just the post-wear map by itself. So let's do it without a subtraction. What do you think is the outcome of the effect here? Is it bullseye, central island, smiley face, frowny face? This kind of looks like the beginning of a bullseye, but it's not a complete concentric treatment zone, is it? And then you've got this massive little island here, so is it a central island? You've got this associated smile down here, is it smiley face? There's a lot of stuff going on in this topography, isn't it? And it's going to be confusing to you in those early days of wear. Your consultants can be a lot of help here. Let's switch over to the tangential because it's not super clear from the axial by itself. You might follow this red ring. What would you say is the position of that red ring? Is it centered? Is it high? Is it low? You know, the pupil is this white circle and it's right on the pupil border here. It's above the pupil margin over here. So I don't know about you guys, but I've seen some suggestion that maybe there's a bullseye beginning to form, that it could be central island, it could be smiley face. You know, all of these things very opposite to each other. So here's the story. Don't sweat one night. If you think that the eye is happy enough, that there aren't any signs that would suggest you got to pull this patient out of wear, just let it go. Because ortho-k full effect is how long? When does it, if we put a patient in a lens, how long does it take to achieve full effect? 7 to 10 days. So if this is a one-night response and you have no idea what's going on, don't worry about it. Let it prove itself out with more time. This was the biggest mistake that I made in the early days of ortho-k treatment. I was looking at that one-night map and I thought, oh, this looks like central island or it looks like smiley face. So I'd make a change to the lens too soon. I didn't let the lens prove out. So here's the same patient after 8 nights of wear. Can you believe that it ended up as such a beautiful bullseye response? That crappy looking smiley face central island and half a treatment zone. So again, don't rush to conclusions. Let's go to the tangential map. Look at that beautiful red ring, perfectly centered. So that's the difference between 1 night and 8 nights of wear. Don't get fooled by your topographies in those early days. Just if your slit lamp exam is acceptable, it looks like you can continue, if the patient was reasonably comfortable, if the vision is improved by even a small measure, then just continue with the same lens. So when in doubt, just continue. Okay, so here are our orthokeratology outcomes. Bullseye, central island, smiley face, frowny face, lateral. It'll be difficult at first to determine which ones they are. Use the consultants. Email the maps off to them. Make sure that they can perform a subtraction. Make sure they've got baseline map, post-wear map, so they can do a subtraction, or you're sending them a PDF of this entire image. So you've got the full subtractive. Don't send just the post-treatment by itself because that doesn't give you the full picture or won't give the consultant the full picture. So just to kind of close up this session, some of the recommendations that I highly encourage that you do is, and this is also referring to our morning session, make sure you got good quality baseline topography. It's so important to your success going forward. Spend the quality time training whoever's going to do the maps. Make sure they understand how to take wicked good maps. That's one of the things. Take multiple images. Never take just one, especially baseline. Take multiple maps. Throw out one that doesn't look like it fits the others. And you're often going to have rogue maps where maybe the lid was slightly smaller on one capture. You've got a little bit of tear film breakup on another one. So throw out the garbage, keep the good ones, build from your best map. Use the subtraction. You've got to figure out how to do this in your topographer. near every topographer I've ever seen has a subtractive map where you can select the baseline, the post-treatment, and then you click on the subtractive function, and it gives you that difference. Remember that this is what the cornea was, this is what the cornea is, but this is how the cornea changed. So the subtractive is so important to you. Train your staff. That's such an important one. Whoever's doing that topography, make sure they understand, how you can get that fissure size open. There's tricks to doing it. Simply just chin forward, forehead back, pulling down on the cheek. That gives you a little more information, and you're not touching the upper lid. If you can, pull back the upper lid and lower lid at the same time if you needed to, if you've got a small fissure patient, any little thing that can help you get more data, because you need that steep axis, you need the vertical meridian to understand what toricity you need in the construction of lens. So not just the horizontal matters, both matter. Take lots and lots of maps. What I do is take 2 maps on the visual axis, 2 maps on the geometric axis, and 1 map in each of the general directions, the 4 principal directions. The idea being I can merge all those maps together and create one larger view of the eye. So that's what I do. If you have really good coverage, if you're able to stretch your analysis all the way across the eye, then you look at the map and it's super smooth, these nice round contours that just follow in this very gentle manner from steepest to flattest. That suggests that you have accurate topography. That gives you confidence in the lens. If you see a high spot next to a low spot, that's not very good topography. It's probably not the real eye shape. When you're using the analyses, use axial primarily. That's one that will help you understand whether it's apical, limbus to limbus, or somewhere in between in terms of astigmatism. And that's something you really want to know as a baseline candidacy. Is it an easy patient? Is it apical? Is it limbus to limbus? Is it going to be tougher? You can't interpret that from the tangential very easy. You got to use the axial. Don't be surprised if 80% of the time or so you get bullseyes, but 20% of the time you don't. Even the best orthokeratologists do not get bullseyes 100% of the time. It's just not possible. We can't predict how lid force and gravity are going to work during sleep. We can't predict where the lens is going to position when the patient just closes and relaxes their eye over the lens. And those hydraulic forces, the way they work, they also affect lens position and outcome. So don't be surprised if you've got something other than a bullseye. That is absolutely normal. And if you've got poor outcomes, like the lens comes in and it looks horrible, this clearly is a lens with excessive sagittal depth. It might be a lens that's not very comfortable. It might be a lens that wants to ride really low and in between blinks. Check the baseline map. If you feel like you've ordered a lens and it's a mile out, I would not reorder a new lens. I would wash the patient out of lenses and I would do new topographies, because chances are if the lens came out this far off, it could be your baseline map that was the problem. Learn how to use learn how to use the subtractive maps. So important to you that, again, there's 2 things I want you to take away from what you might have heard from me today. Really good baseline maps, learn how to use the subtraction. It's going to be your best friend in ortho-k. The consultants are going to be uber valuable to you because they are going to help you through the whole process. So, hey, I hope those 2 sections have been valuable to you. And if you have any questions, I'm floating around, so don't be afraid to ask. Yeah, quick question?
With the axial map, would you use that for if you were to do like a level fee structure? Would you, like if you were to say, okay, I'm not going to do 6 levels, but I'm going to do 3 levels, and dependent upon the actual map, that's what I'm going to charge my fee?
Yeah, I think that's a great idea. So the question is, can you look at the axial topography and have it guide your fees, your decision-making on fees? And yeah, if it's a symmetric eye, if it's a spherical eye, if it's a apical astigmatism, I'm thinking easy case. If it's limbus to limbus, I'm going to jack that up.
And then this may be a lab question, purposely choosing that 8-day follow-up because the labs have like a doctor's change, like a one-time, like you have to get all your information correct before you go back to the lab to tell them, look, I ordered this lens, but I did an 8-day follow-up and I really want you to make these changes?
Yeah, so the follow-up schedule we typically use at the school is one night. Everybody comes in after one night to make sure we're not off on the wrong path. The second visit can be almost anything, a week or 2 weeks, but we want the lens to get to full effect. And as you know, full effect is 7 to 10 days. So if we're able to see the patient after we know the lens has achieved its target, then we can see, predict what is the true outcome of this case. Yeah, the question was, would the lab come back and work with you? And it's pretty typical that their exchange fee or their exchange duration is months, so that you've got that amount of time to reorder the lens if you needed to and do another refit. Do we have another speaker? Yeah.
Maybe at a time. Yeah.
Oh, okay. Thank you, everybody. I'll be around, so